I will try to talk about reverse shoulder arthroplasty in a rotator cuff arthropathy case, results and expectations. So, reverse shoulder arthroplasty, we know from 1985 from Dr. Paul Grammont, and the main indication was for rotator cuff tear arthropathy. And since then, it's been used for the last decades, and we witness increased use of this procedure for the last decades, and with excellent clinical results. Especially, it's the treatment of choice for cuff tear arthropathy. I can say it's the gold standard. And these increased results are maybe because of the experience of the surgeons and also for the decreasing of the complications. And nowadays we have expanded indications. We use reverse for massive rotator cuff tears, primary osteoarthritis, proximal humor fractures, revision surgeries, and also for tumors. But if we see the Australian Joint Registry, at 2009 we have almost 42% of reverse, and nowadays 2080, almost 80% of the cases of prostheses in the shoulder are for reverse shoulder arthroplasty. And also, when we are dealing with rotator cuff arthropathy with a reverse, 10 years survivorship, we have almost 94% of survivorship. So it's a good indication. But what about complications? We see that almost 7.4% in this systematic review, this is a systematic review with the last cases, we see that complications can be instability, infection, loosening, and also periprosthetic fractures, almost 70% of complications. And this led to a revision in the variable clinical outcomes. At 5 years, 4.2% of the reverse were revised when we are regarding the Australian registry, and at 14 years, 7.8% of revisions for reverse shoulder arthroplasty with a CTA case. So we also know that there is an increased risk of revision when we are dealing with young patients, especially males, and most of these revisions, almost 67%, are in the first year post the surgery. So what about the clinical outcomes? What about the results? If we see this systematic review, when we are looking just for the cuff tear arthropathy, we see that all the movement, all the range of motion, there's an improvement, 62 degrees inflection, 6 degrees abduction, external rotation between 17 and 27 degrees of better movement. Also, the PROMS, the pain score, less 5 points, also the AZ score, the constant score, and the SST score. We have better scores when we are looking for PROMS, when we see these systematic reviews. What about the preoperative disease severity? We can also say with this paper that patients with greater CTA disease progression did not show different outcomes comparing with patients with milder disease. So reverse shoulder arthroplasty, even with a CTA great erosion, we can achieve almost the same results as a middle case. In contrast, poor preoperative function and poor degenerative changes were associated with greater satisfaction when we use reverse shoulder arthroplasty for CTA cases. And what about the deltoid size and fatty infiltration? This paper shows us that preoperative deltoid size are correlated positively with postoperative constant score, AZ score, subjective shoulder value, and strength. Also, the quantitative deltoid fatty infiltration is correlated with a decreased postoperative AZ scores. And also, the quantitative fatty infiltration of the infraspinatus, we are correlated with a post-operative, less post-operative external rotation. And also the effect of the patient gender on outcomes. This paper shows there's an improvement in pain and range of motion were similar between males and females. Males achieve a higher AZ score and SF12, score, but there are no difference when we compare the range of motion. Maybe women are more functionally impaired on the basis of differences in a daily basis. So maybe for female, daily basis are more impaired when we use RSA for CTA. Also, we have to pay attention when we look for this paper that shows us that there's a high mobility, a bigger range of motion at 24 months post-RSA, but also the scapulothoracic rotation has a significant great contribution for the elevation of the arm comparing to glenohumeral elevation. That is not used to see when we do a control case. So maybe we should look, when we do the rehabilitation of these cases, we should look for a better for the scapulothoracic rotation. And what about future? We see that when we are dealing with the reversal arthroplasty, usually we can say that the gold standard is the Graham design, the medialization of the center of rotation allowing the humerus, but we have some kind of problems, scapular impingement, sometimes instability, and also static, like loss of shoulder contour. What about correction, the glenoid erosion and lateralization of this center of rotation? The advantages, we can less scapular notching, better stability, better mobility, especially rotations, better shoulder control. When we do this, should we have a better or higher implant survivorship, better results? Maybe when we try to correct this eccentric erosion with a reverse in this kind of patients, it's a challenge, and probably the best way of achieving this is computer-assisted, like patient-specific instrumentation, and maybe it's probably the best way to achieve the better correction and to be more reproducible when we are dealing with these eccentric glenoid erosions. We can use it bone, we can use it like Pascal Ballot told us, angled RSA. We can use it metal options like metal augmented base plates, full wedge, half wedge. And when we look for the papers for BRSA, the survivorship can be at 96% with a graft incorporation of 96% and less scapular notching, like 80% when we're looking for these papers. Also, comparing Mio RSA metallic with bone, there seems to be, when we use metallic as a suitable alternative when comparing to bone, bone and metal augmentations provide good clinical and radiographic outcomes, and maybe there's a concern about using base plate with a bone, long-term results, so we should expect and be cautious when we use bone. So questions to be answered when we use a reverse to treat cuff arthropathy. The correction of this axis. Should we use a PSI? Should we use a computer guide, artificial intelligence? Should we use bone or metal? What are the limits of this correction? Long-term results. Should we have, if we correct the axis, long-term, higher implant survivals? I think there are some questions to be answered. And to take home message, a reverse is a reliable option or solution to improve clinical outcomes when we are dealing patients with cuff arthropathy. We witness low complication rates, so it's a safe and efficacy is very efficacious when we use a reversal arthroplasty. The lateralization of the center of rotation likely contributes to improve the clinical outcomes. And in case of bone loss, type B or type C, there we can use BRSA or MRSA, but we should be careful and we should look for longer-term follow-ups. We need long-term follow-ups to comprehensively evaluate the effectiveness and durability of these new RSA implants. So thank you.